Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, and I'm very happy you're joining us for another episode in our Fireside Chat series, where we take a step back and have thoughtful, practical conversations about the data shaping how we care for patients. In today's episode, we're going to interpret the Select Switch trial and what it actually means for RA care. This is a topic that I think so many of us face in clinic. What do you do when a patient isn't responding the way we had hoped after a TNF inhibitor? Do we cycle within the class, or is it time to switch mechanisms altogether? We're going to walk through the Select Switch trial together, why this study was needed, how it was designed, and what makes it different from prior data. But more importantly, we'll focus on what it actually means for our patients, how to recognize when it's time to make a change, how to interpret efficacy and safety in a meaningful way, and how to have those conversations with patients sitting right in front of us. I am joined by two fantastic guests, Jeannette Hart, who is a PA, and Dr. James Levine, who happens to be my collaborating physician. And they both bring both deep clinical expertise and real-world perspectives to this discussion. So, Dr. Jamie Levine, can you give us a brief introduction since this is the first time that you are on RhAPPcast?
I am honored to be here. Really a pleasure to have the opportunity to talk. So I'm with the UC Health System in Colorado. I have the privilege of knowing Amanda and working with Amanda for a number of years. Very busy clinical practice with multiple sites, full breadth, full scope rheumatology across the board.
And Jeannette, do you want to do a brief introduction since you also have kind of exciting news regarding your clinical practice?
Thanks, Amanda. Yes, I have a private practice out here in Washington State. We just opened in October of 2025. Prior to that, I've been working in rheumatology for about 14 years. I have a collaborating physician here, Dr. Derek Peacock, and I just get to have the joy of practicing private practice rheumatology, which I was missing out working for a large hospital system. Again, just like Dr. Levine said, I do the whole gamut of rheumatology, and I'm excited to talk about this study today.
Thank you so much. And I always think it's exciting to have people that are kind of in the trenches, you know? I mean, we are all seeing lots of patients, seeing complex disease processes and treating these patients every day. So I think it really helps bring some of these studies that we talk about to, full life because we're actually doing this on a day-to-day basis. So with that, I'm going to go ahead and get started with some questions for you all. Dr. Levine, let's talk specifically about why this study matters. So why was a head-to-head trial like Select Switch required in RA management, specifically after TNF inhibitor failure, and what practice gaps does it address?
Yeah. So TNFs, as we all know, are really the first biologics, aside from anakinra, to come out. We're standard of care. And for a number of years, that was what we had. And so if a patient failed, cycling through TNFs was kind of your only option, unless you wanted to revert back to prior therapies. Usually when people got to that point, they'd already tried them and they had failed. There have been studies in the past and registries that have looked at what to do when a TNF fails, but they're all open label studies, observational European registry type studies that gave great insight, but really weren't direct head-to-head trials. So this study in particular is really our first direct head-to-head comparator study looking at what to do when somebody fails a TNF inhibitor.
Let's talk about the study design and methods. So, Jeannette, what was the design of Select Switch, and what are the key details clinicians should understand when reviewing the results?
Okay, so the study design here, the whole goal was to look at patients who had failed a TNF and then to separate them or randomize them 1-to-1 in an arm to receive adalimumab or Humira, and then the other arm would be Rinvoq. So basically coming off of another TNF. Obviously, that could not have been a Humira, so any other TNF. The majority of them were on Enbrel, to be specific. All of the patients had pretty moderate to severe disease activity with greater than 6 tender swollen joints, elevated inflammatory markers, and then all of them had to be on a stable dose of methotrexate going into the trial as well. So pretty classic rheumatoid arthritis patients. And then they were evaluated, and the goal was to look at which group could reach the primary outcome, which was low disease activity. And then they also looked at remission rates. If we would just cycle onto adalimumab off of a TNF, or to move to a different mechanism of action like RhAPPcast, a JAK inhibitor.
How does the patient population in the Select Switch study differ from those enrolled in prior trials, and what implications does this have for interpreting the results?
Well, I think specifically these patients had been on a TNF, all of them, right? So we're moving off of a TNF and put on either a TNF or a JAK inhibitor. And a lot of patients in the other studies that we look at have been on adalimumab. I mean, that seems to be the TNF of choice nowadays. And they all had a decent amount of disease activity. They also didn't exclude patients with cardiovascular risk factors. So those were included in this. Those patients were included in this study as well, equally, of course, in both arms. So when that's something that we think about nowadays when we're reviewing safety at the end of a trial, those patients were included.
Dr. Levine, when you look at strengths and limitations of this design, particularly how it mirrors real world decision making, do you see anything, strengths or limitations, weaknesses?
Well, as Jeannette said, I think the strengths are that this was a well-established rheumatoid arthritis population. Average disease activity was 10 years. 40% of them were on an average dose of prednisone of 6 milligrams. So these were definitely active patients. So I do think it's pretty representative of our poorly treated population of rheumatoid patients. I think it's curious what a high percentage of them were on etanercept. That kind of strikes me as maybe a little bit unusual. I'm not really sure why that is, but otherwise it was 2/3 female, average age in their 50s. I mean, this is a pretty typical makeup for most rheumatoid studies.
So, Dr. Levine, thinking about the adalimumab to upadacitinib scenario, or TNF to JAK switch, what clinical scenarios would make you consider switching instead of cycling? And how do you explain the difference in mechanism of action to patients?
Yeah, sure. I've long been a proponent of switching versus cycling for rheumatoid arthritis. Part of that is just born out of experience. This kind of does parallel what I've been through in my years in practice. But it also, again, is supported by prior studies. There was a study in 2016 called the Rotation or Change Study, and it was open label, and it was they looked at switching to an alternate TNF versus, at the time, rituximab, abatacept, or tocilizumab. Now, again, it was open label, but again, you did have better responses when you switched mechanism of action versus switching within the class. So this is supportive of that data. It's supportive of the data that we've seen in the European registries as well. And so I think that this study is good, uh, glue to sort of bring together what most of us really think about. But it will have impact in real world. It will have impact on insurance companies, and it'll have impact on what we can do on a day-to-day basis. In terms of my conversation with my patients, I try to describe to them that the immune system is an incredibly complex um, organ system. I mean, outside of the central nervous system, I think it's the most complicated organ system in the body. And if anything goes wrong, then the orchestra is out of tune, and we've got to get it back in tune again. And sometimes the only way that we can do that is by trying to target a different part of that immune system. And that's where this comes into play.
Absolutely. I really like how you kind of talked about it as an orchestra. And I totally agree. The immune system is so complicated, which is why every year that I'm asked to do immunology, I kind of take one of those, oh gosh, not again. Because it is, and it's so hard to understand. Jeannette, what do you think about this? Do you immediately go from a TNF to a JAK, or perhaps a different mechanism of action, or do you stick with it?
I think first of all, were they, the primary responder versus second or non-responder versus a secondary non-responder? I think in this study, I'm looking at it now, the majority of the patients were primary non-responders. So that means they really didn't, let's just talk about etanercept, for instance, really didn't respond to that drug within the time frame in which we would expect, rather than it sort of petering out over time or disease busting through. So I think that that's interesting. Historically, in my practice, if a if a patient was a primary non-responder, I would have definitely switched mechanism of action. It was always that secondary non-responder that, just stopped responding over time that I took a pause, and I probably cycled previously, years back. But, as the guidelines have come out, 2021 with new rheumatoid arthritis treatment guidelines, then we have EULAR in 2025 encouraging us not to cycle. I think that sort of pushed me to say, okay, well, then what? Which mechanism of action? And I I really feel for new APPs coming into practice. You and I got to start with one mechanism of action almost at a time to learn, and we've kind of guided our treatment algorithms by what not to prescribe to patients based on their comorbidities, rather than how their disease phenotype might look and which mechanism of action I just anecdotally from my practice I think the patient will respond to. So I think this is from a real world perspective, this might help clinicians say, okay, from a standpoint of finishing or not responding to a TNF, obviously they're going to respond much better to a JAK inhibitor based on this study, especially if they're a primary non-responder. And then later on, when we talk about safety and all of that, we can feel comfortable making that jump from TNF to JAK, where, after some of this initial safety data of those JAK inhibitors came out, we may have saved a JAK inhibitor for later on down the road, where now we know we could use it as maybe a second line biologic or targeted synthetic agent.
Well, and I really want to get into specifically the efficacy of this trial. So, and you kind of alluded to that, Jeannette, but can you talk to me about the key efficacy results and then how we should really interpret those efficacy results in terms of meaningful change? What does higher LDA or remission rates translate into, like quality of life or joint damage or long-term outcomes?
Yeah. I think it mimics what we want to do nowadays. We talk about this all the time on your podcasts about how there's no more room for complacency when treating rheumatoid arthritis because we have so many treatment options, and there's no room for leaving patients on steroids. So what the goal is to get to low disease activity and or remission by just 12 weeks. We usually counsel our patients that by 12 weeks drugs supposed to be at full efficacy. And what they found is a significant portion of patients that were put on that upadacitinib reached low disease activity or remission by 12 weeks, which is great. That's what I want for all of my patients. So as far as efficacy goes, it's certainly there. And not only were the results very statistically significant, but numerically very different as far as the responders on the Humira arm versus Rinvoq arm.
So, Dr. Levine, I have a question for you because this is something that, sometimes I struggle with, right? Like you put a patient on, pick your TNF that you decide to give. I don't know. I'm struggling with adalimumab because I don't know which one they're going to get, and it can be just such a pain. But whatever one you choose, right? So you see a patient, they come back in 3 months, and what is it that they say to you that makes you say this is not working?
What they say to you and what you see, right? So certainly what they say to you are the subjective complaints. It's the pain, it's the stiffness, it's the swelling, it's the function. Sometimes it's the fatigue, harder to interpret, but that's usually part of it too. And then of course, it's your clinical opinion as well. The labs always can be helpful, but not always, not always. It's always that situation where somebody looks terrible, but the labs say they're doing great. You just can't go off the labs. So it's really that whole combination. I tell my patients, we make decisions based on what you think, but also what I think. Sometimes what the labs say as well. We got, really bring it all together and try to take a holistic approach to this.
It's so true, and sometimes, you put somebody on one of these therapies and, perhaps they haven't ever or haven't felt this good in years, and so, I don't know, sometimes they're hesitant to wanting to make a change, even though sometimes you look at them and you're like, "Oh my gosh, it's been 6 months and you still have several swollen joints, but you feel better." So then it's like trying to convince the patient like, "No, no, no, I know that you feel so much better than you did before, but, like, damage is still occurring, like, we probably still need to make a change or add something or do something different." So trying to have that conversation with patients can be very challenging for a lot of different reasons.
Very challenging. And, the limitation of rheumatology is we're still in a guessing game scenario here. So, going back and looking at this study and thinking about it, yes, it certainly supports switching over to upadacitinib. but that doesn't necessarily mean it doesn't support switching over to a different mechanism of action. And it's still just a guessing game. I think, even starting with the TNF is still, in my opinion, rather arbitrary. I think from a medical basis, from an intellectual basis, I think you could be justified starting with almost any medication until we have a tool that helps us to predict pre-treatment what somebody will respond to. So we talk about the strengths and the weaknesses of these studies. I think one of the weaknesses of the study is we are just talking about upadacitinib. And yes, it works quickly, and yes, we're comfortable with it. But it doesn't mean it's your only option out there.
Yeah, I have to agree with that. And we know upadacitinib works quickly. And if we go back to the patient population that we're looking at, were primary failures. So they're already frustrated with heart disease after we've made them stay on a drug for probably close to 3 months, maybe a little under, right? And so they're frustrated. And sometimes in that moment, other than throwing more steroids at them, I'm thinking, I want a drug that I know is going to work quick. I know the JAK mechanism of action works quickly when it does work. Sometimes same with IL-6. So sometimes I'm thinking about what can I give them? I've already failed them once. We have a certain ownership on, we promised them the moon with the first biologic, hoping so much would come out of it. And sometimes it doesn't pan out. So choosing, moving on to a very quick working drug is, I base it on that too.
It's a good point.
Well, and I think that also gets us into, talking about the next topic, which is going to be safety, because certainly when we're thinking about what therapy to pick for someone, we have to think about their comorbidities. We have to think about the safety of the drug that we're going to put them on. So, Dr. Levine, when you're thinking about this particular study, what safety findings emerged from this trial, and what practical monitoring or caution points should clinicians keep in mind when switching from a TNF to a JAK inhibitor?
So in this study, between the two study groups, and emphasizing that this was a 12-week outcome. So it is hard to look at real safety outcomes at such a short trial. At least in this trial, there really were no meaningful differences between the two study populations. That doesn't surprise me. Maybe with the upadacitinib could have seen some mild cytopenia, but really in a 12-week time span, that's about all we need. And so it really does beg that we need to have longer data if we're really going to be looking at safety. But be that as it may, I met the primary outcomes. With upadacitinib, we would be looking at the CBC to check for cytopenias. You would keep an eye periodically on the liver tests every several months. Everybody's got their own personal preference. I usually check them 8 weeks after starting, and then usually go out to about 3 months, depending on what other medications or comorbidities would be there. Certainly with JAK inhibitors, we do have to worry about shingles. None were really seen in this, but again, it's 12 weeks. It's hard to make too much out of the 12-week trial.
Yeah, and I think also, when you're thinking about these patients, it's like, okay, what have you had a history of a stroke? Have you had a heart attack? Have you, because then it might shift you a little bit towards perhaps a different MOA. Jeannette, is there anything else that you would add when you're like talking to patients about switching from a TNF to a JAK?
I mean, I will always bring up that, hey, I'm going to mention 3 very scary things: malignancy, DVT, and cardiovascular risks, because that is on a label, and that I am mindfully picking this drug. If I'm prescribing it to you, then they're usually not morbidly obese, smoking a pack a day, taking extra hormones, haven't had a history of an MI or a DVT. I do take those things into consideration. Obviously, upadacitinib's safety data looks a little different than some of the other JAK inhibitors for what that's worth. And I just talk to the patients pretty frankly about that and say, I think you'll do very well on this drug. I've seen good things with it. I expect it to work quickly. But I do want you to know that these are some risks that we're taking when prescribing it to you. Again, as far as this study goes and the safety, I have to mimic that it was 12 weeks. I did think it was interesting. There was slightly more herpes zoster in the adalimumab arm. But again, they were allowed to kind of play with prednisone to a certain level. I think it was like 10 milligrams or something. Lots of things could be playing a role there.
Yeah, I totally agree. And, again, the interesting thing that I find is if we're talking about specifically a patient that has already failed a TNF, I find that when you start to talk to them about other MOAs that have potentially different, complications or toxicities that are possible, they don't seem to really be that concerned about it. I always feel like the very first conversation when you're like, and you can't have a history of da 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 da, and you can't do this, and we have to look for this and all that. By the time you get past that first one, they just want to feel better. And I, at least in my experience, it really doesn't phase them when I'm talking to them about this. And I also will say things like, would I take this? Yeah, absolutely. Would I give this to my sister? Yeah, absolutely. Do we need to be cognizant that if you've had like a blood clot? Yeah, probably I would maybe not do this particular MOA unless I had no other options or something. But I think it's just, important having that conversation. But I don't know, would you agree, Dr. Levine? Like after the first one, when you have that conversation, they don't seem to be as worked up about
Yeah,
it?
typically at that point, they've been on other drugs. They just want to feel better. To dovetail on Jeannette, I agree. I also discussed the three big bad things, but I also say, this really wasn't with this drug. Now, and that's worth mentioning. This really was with Xeljanz, and Xeljanz and Rinvoq, while similar medications, are not the same. The history there was that the study really was, the safety signal was with Xeljanz. The FDA decided to extend that box warning to the class. One could argue whether that was appropriate or not. I think it was appropriate because, again, it's conversation, yet we still haven't seen those results replicated with Rinvoq. Now, lack of data doesn't mean that data doesn't exist, but I'm the same. I'll tell my patients there are three bad things, but we haven't really seen it in the real world. And I agree. This is likely to give you a really good, quick result. And most people buy in.
Yeah, and I totally agree. That's the same conversation that I have. So Dr. Levine, I mean, and I already think I know the answer to this, but does this data change your real world approach, such as like when you might choose to switch from a TNF or how you'll communicate with patients?
Uh, Mine, not really. I think maybe it's reinforcing, but it doesn't really change my approach. I have done this. I came to the realization observationally years ago that when somebody, particularly primary failures, if they failed, they weren't likely going to do well again.
Jeanette, anything else that you would add?
I do like to talk to my patients a little bit about guidelines and why I'm making the changes that I'm making. And so I might say, we've known the guidelines for a long time, support not cycling. I know your sister has been on adalimumab and she did well, but you really didn't do great on Enbrel. So guidelines suggest that I should make this change for you. I truly feel like this is the best option for you. And so I like to have things like this, studies to help support guidelines. That way I can have a good educated conversation with my patients.
Awesome. Well, thank you guys so much for all of your expertise. I really, really appreciate it. And I think this will be really helpful to our listeners to just understand what this, shows, but also, how we can interpret that and talk to our patients. But, we have patients listening, we have ABPs listening, physicians listening, and I think understanding that, it may be time to make a change or is likely time to make a change after that first TNF. So again, thank you both for being here. And as always, thank you so much for joining this episode of RhAPPcast. I hope today's conversation gave you not just a clear understanding of the SELECT Switch trial, but also practical insights you can bring into your own clinical decision-making, especially when you're navigating those moments where it may be time to switch rather than cycle. Again, thank you so much to Jeannette Hart and Dr. James Levine for sharing their expertise and real-world perspectives. And before we wrap up, I want to personally invite all of you to the RhAPP National Conference happening September 23rd through 26th at Caesars Palace in Las Vegas. Dr. Levine, you should come.
I might.
This is more than just a conference. It's your home. It's where rheumatology APPs come together to learn, connect, and grow with education designed specifically for you by people who understand exactly what you do every day. Come get your CME, listen to amazing presenters, and connect with your community and be a part of something that's truly built for you. Thank you again for listening, and we will see you next time on RhAPPcast.